My name is Marissa Padron. I work at the Connecticut Women's Consortium, and I have the pleasure today to introduce our first presenter, who is Gabriela Koch. So Gabriela works at the Office of the Treasurer as the Engagement Manager. She's currently organizing the Connecticut Baby Bonds Ambassador Initiative, which is a network of trusted community messengers committing to spreading the awareness of the Connecticut Baby Bonds program and on being engaged stakeholders throughout the implementation process. As part of this effort, she has been connecting with various nonprofit professionals, coalitions, service providers, and advocates for children and families. She currently lives in Stamford with her 2 cats and spends her time outside of work serving on local boards and advocating for public education. She's a proud immigrant, fluent in both Spanish and English, and is passionate about the impact of Connecticut baby bonds and what it will have in our state for generations to come. I'm now going to pass it over to Gabriela.
So just to give a brief overview of what Baby Bonds is, I see some familiar names on the call, but just to kind of give you a quick recap on what the program is, we're a first in the nation initiative that essentially invests money, specifically $3,200 into what you can call a mini trust fund, if you can really compare it to that, for every child in Connecticut whose birth is covered by Husky. The birth covered by Husky aspect is really important to the program because we're essentially using that as a marker for children born into poverty, right? Really addressing this wealth disparity that we see in Connecticut, which is one of the wealthiest states in the country, yet we do see a large wealth gap among our different counties and also municipalities. So the $3,200 is invested into the child's mini trust account, and between the ages of 18 and 30, they can make a claim for those funds for the following purposes: to buy a home in Connecticut, save for retirement, pay for post-secondary education or job training, and to start a business or invest in a business in Connecticut. Now, when they do reach that age between 18 and 30 years old, at the time of making the claim to access these funds, they have to be a Connecticut resident and they have to have completed a financial literacy course. And a really important piece, which does make the program a little bit different than other, you can call it, government assistance programs, but this is really something that parents don't need to apply for. There's an automatic enrollment, right? You don't need to fill out any application or anything. We collect this data on the births covered by Husky via the Department of Social Services. And so with that data sharing agreement, we're able to get the automatic amount of babies known so we can open the accounts up, as well as contact info. And this is just a quick kind of insight on the origins of the policy, right? And it's not only smart social policy, but we really see it as a smart economic policy, really investing in the long term for the state. We're estimating between about 16,000 children every year are born covered by Husky in the state. If you think about that, that's about half of the births in the state that would qualify for this program. And it's also expected that every single municipality will have a baby bonds baby, no matter how rural or densely populated. So just to kind of talk about where we are right now, we formed the trust account. It's funded starting July 1st, 2023. Every child who's born is eligible for this program, receives the funds. We opened up a 501c3 sleeve to really try to hone in on philanthropy support, really hone in on wraparound services. We really envision baby bonds as a vehicle to really provide baby bonds families to connect them to services across the state, right? We have a plethora of nonprofits and services provided by them in the state. And so we really want to make sure that the families have access to that on an age appropriate basis. We want to make sure the beneficiary makes it to 18, right? And so currently the top priority for us is really this family notification piece. We're working internally right now to really get this first contact letter out to families, really trying to get this data out. And there are some nuances in getting the data from DSS. For example, you don't want to send a letter of notification to a child that has passed, which we have come into. So you just want to make sure you really scrub the data and make sure it's as accurate and as updated as possible. And now this brings me to the Baby Bonds Ambassador Program, which is about this community engagement and wraparound services piece. We really know that on top of a larger marketing plan, which we are working on, with a plan and a vendor, we do need to acknowledge that grassroots contact is going to be really crucial in a program like this. It takes a lot of trust to tell a family, hey, by the way, this program is eligible for you. You don't have to apply. When I do tell parents that, they do get a little bit hesitant and they're like, are you sure? What do you mean? I don't have to do anything. Folks can be a little anxious about that aspect to it. And if you think about it, it's also a long-term thing. So you want to make sure you're engaging the family and the parents from 0 to 18, right? Throughout the process. And so some things that I tell ambassadors, if you're an organization and you would like to sign on to help spread information, sign up for our listserv, which sends you constant information on the implementation process and all things CT baby bonds. We ask that you can help by talking to families about the program, provide them with materials. We have one-pagers and other materials we send out to ambassadors, displaying the flyers in your office or your waiting areas if you're a case manager. You can, if you have like an introductory folder, you can put it in there if you identify a baby bonds family, handing them out at events in your digital newsletters, and also posting on social media and just making it visually known that you know about Connecticut baby bonds and that you're an ambassador. We also ask, you know, right now we're translating materials. If you have that ability to provide translation for, you know, languages, it's appreciated, but definitely it just takes us a little bit longer when you go through the regular vendor process. So we have had really great support from our ambassadors in providing translation support for different materials. I think also the most important part about ambassadors is this advocacy piece and policy support. The program is being implemented as we speak. The administrative process is being fleshed out. I think what's important is that when you're on the ground working with families directly, you're able to provide feedback and insight that we don't necessarily have, right, from a policy perspective. And so that's really crucial in making sure when we're developing the website and the portal for families to check out their funds and how it's growing, that we have that insight, and also on how we structure some of the wraparound services part. And I think also important to note here is that we have funding currently for 12 years. So for 12 cohorts of babies, we have funding secured. So we are looking to identify a permanent revenue stream, which obviously would require advocacy, would require people who understand the impact and importance of a program like this to show that support during a legislative process. And I've also been connecting with case managers, service providers, and advocates who work directly with families and parents who qualify for baby bonds. And usually what I tell them is, you know, you can help spread the word by just knowing how to identify a baby bonds family. They had a baby July 1st, 2023 or after. That baby is covered by Husky, that birth is covered by Husky, then you know that's a baby bonds family. And so we encourage you to just be able to identify a person when you see them, a baby when you see them, and then give the information, share specifically that the automatic enrollment piece is super important to share. I want folks to just make sure that that is really key to this program. You don't need to fill out anything. We can't emphasize that enough. And then also, if you have colleagues of yours that you think would be great in getting access to this information, being added to our listserv to receive these updates and materials, we encourage you to connect them with me so I can get them set up and send them the folder of resources that we have. And then also just, again, share your feedback with me. If you find a family that has a very interesting situation, where you don't know whether or not they qualify, we can definitely get that situation addressed and answered. We have an FAQ document, and we're constantly adding more questions to that as they arise. And this is just general email for baby bonds. I do have access to this. I'm bilingual in English and Spanish, so I am able to communicate with families and parents that reach out via that avenue. And then my personal information, my email is there as well.
Our next presenter today is Dr. Nancy Grechko. So Dr. Grechko is a clinical psychologist and founder of Grechko Trainings and Consulting. Besides providing direct clinical care in her community with low energy neurofeedback, she also supports mental health practitioners and organizations through clinical supervisions and consultations, as well as continuing education training. She's best known for making even the most complex clinical concept accessible, so practitioners walk away with tangible tools and that they can integrate into their practices. Dr. Greco is passionate about supporting mental health practitioners do their work and do what they love while taking care of their professional and personal needs. So I would like to pass this over to Dr. Greco.
Hi, good morning, everyone. I'm so happy to be here. Thank you for the introduction. We're good to go. Okay, so today we're talking about clinical documentation. And, I know clinical documentation gets a bad rep. Nobody loves clinical documentation. It is the bane of our existence. For many of us, we came into this field to do the work, and the paperwork is like this side project, right? Like this the annoying thing that you have to do in order to get credit for your work and to get reimbursed. And just to justify all the amazing work that you're doing. But I want to shift the mindset a little bit because clinical documentation really can be your ally. It can be your best friend. It is more than just paperwork. So, why is this important? Well, clinical documentation is the testament of your work and your client's work, as well as their medical record. And all clients deserve to have accurate and up to date records. At any point, a client should be able to come in and say, I would love to see my record. I want to know what's documented, and it should be ready for them. So, when we have a large time lag, when we are not up to date on our documentation, when we are not providing medical necessity, we're actually part of, in my opinion, an oppressive system that is not advocating for our clients. So clinical documentation is not just this annoying thing that you have to do, it is part of the clinical work. So a little note here about language. I say a little note, but it's actually a big note because it's really important. I am a huge proponent of strengths-based, non-judgmental language. This is super important in the record because how would you want to be described? How would you want the most vulnerable parts of your life described in a medical record? We want to use language that is both accurate and non-judgmental. So especially if we're talking about talk screens, we're talking about positive versus negative test results versus clean and dirty because there's judgment there, right? Like there's a negative connotation. I know a lot of folks in their clinical documentation that I review, they may talk about attention seeking behavior or manipulative behavior. That is not helpful. As a psychologist, that's not helpful to me. It doesn't tell me what you're experiencing and what's going on for the client. So we need to think about the language that we're using rather than attention seeking, we're connection seeking, attachment seeking. For folks who are engaging in quote unquote manipulative behavior, again, that tells me nothing. You need to behaviorally define that. What are you actually seeing? Client is doing X, client is doing Y. It's going to take you a little bit longer, but it's more accurate language and it's more helpful when it comes to documenting what your client's going through, when it comes to medical necessity, all of that. So be mindful of shortcuts because sometimes, well, all the time, judgments are shortcuts. We know what they mean. But when it comes to clinical documentation, in order to be strengths-based for your client, in order to be person-centered, and in order to justify the work that we're doing, it's not helpful. But I do want us to work smarter, not harder. So I'm going to show you how to do that today. We're going to start with the intake. So we're going to go from the intake all the way to termination. So first things first, when it comes to the intake, this is an intake assessment, not the entire assessment. We are assessing throughout treatment. And I usually tell my clients that from the beginning, it's going to take a few sessions and gather in some information. The purpose of today is that I'm going to ask you a bunch of questions to get through our intake process. And then we're going to create a treatment plan or, whatever the protocol is for the program that you are a part of. I think we need to take some pressure off because for a lot of the folks that I support, they feel like they have to get everything in that first session. You don't have to. The purpose of the intake is to get enough information to get to a diagnosis. And to get to a diagnosis, you need to ask about frequency, severity, duration of symptoms, the challenges that they're experiencing, how they got to where they are. But we don't need to go into all the details of the life story. This can be pretty tricky because for a lot of folks, when they come to you, this is the first time they're talking to someone. This is the first time that they're in a clinical setting and they want to let it all out. They are ready. And so, I always tell folks, listen, I'm a psychologist, I'm a therapist, and I want to ask you all these questions and I want to go deeper into the work. But for today, I have my assessment hat on, I have my intake hat on, and I need to get through these questions. I always orient the client to the expectations and that the purpose of the intake is to answer the questions. And in this way, I also ask permission and consent. I say, you know what? We have a ton of questions to get through today. We're going to have plenty of time in our work together to get through the details. Is it okay if throughout our time together today, I keep us on track? There are going to be times where you're going to want to tell me more, and I'm going to try to bring us back to the questions. Do I have your permission to do that? And normally folks will say, yeah, sure, no problem. So that when you do have to redirect the client or whoever you're supporting, they don't feel like you're cutting them off. They don't feel like you're invalidating them. You're saying, hey, I so want to hear more about this. And I know your clinician's going to want to hear more about it too. But I'm going to come back to this question. Okay. So let's put a pin in that. And I'm going to come back. And they say, oh yeah, sorry. Okay. I went on a tangent there. But they've already given permission. You've already oriented them to what it was going to look like. So this completely changes the vibe of the intake. We have to include symptoms in the intake. That's why we're here, right? The purpose of the intake is not to get the entire life story, not to go deep into this person's, experiences and how they're walking through life, but to get to a diagnosis. That is the purpose of an intake. And also, so we have enough information to decide, is this an appropriate level of care? How are we going to make some clinical choices here? So intakes and treatment plans need to include specific symptoms, and they need to include these three things: frequency, severity, and duration. Frequency meaning, how often is this happening? Is this happening all day, every day? Is this happening once a week, on the weekends? The severity, how bad is it? How intense is it when it happens? On a scale of 0 to 10, how intense is it? How severe is it? The other question I like to ask here in terms of determining the severity is, do you feel like you can control them? Is it easy to control or difficult to control? So when you have intrusive thoughts, when you have urges, are those easy to control or difficult to control? That gives you a sense of the severity as well. And then the duration. That question about easy to control, difficult control also gives you some information about duration as well. So does it stick with you for a few minutes and, no big deal? Or does it last hours? Does it last days? Some people, when they're feeling depressed, they say, listen, once I head down that spiral, it's really hard for me to come out. And that gives you a sense of duration. And that question of, is it easy to control, difficult to control, also gives you a sense of duration. This is so important because this is what determines medical necessity and serves as the golden thread between the intake and then the treatment plan. So you're going to hear me referencing the golden thread. The golden thread is this idea that from the time of intake to the time of discharge, there is this golden thread that connects everything together. And this is all from medical necessity and the symptoms and the diagnosis. At the intake, you create, you're able to gather enough information to determine a diagnosis. And this is through all of the symptoms, the frequency, severity, duration. That's going to then inform your treatment plan so that we can improve those symptoms. Your treatment plan is then informing your progress notes, because your progress notes should always be linked to your treatment plan. And then you're going to summarize that in your discharge summary or in your termination note. So that golden thread is throughout. Please keep in mind that all symptoms, everything that your client tells you, is reported unless you see them for yourself live in session. So this comes up a lot with, I see it in relationships where a clinician will say, client is in an abusive relationship, client is in an unhealthy relationship. I am not seeing this partner. I do not have this information. So I can say client states that she feels like she's in an unhealthy relationship. Client reports incidents of, verbal attacks or domestic violence, intimate partner violence. Everything is reported. Now, I know in our documentation, it can get really annoying to say client reported, client reported, client reported. We can be a little bit creative with that, but it's also okay. No big deal. Like, this isn't your English lit class. It's totally okay to use client reported 1,000 times in your documentation. But you could also use client stated, client expressed, client indicated, client explained. With further questions, client was able to describe. You can, if it bothers you that much, and I've been there where I'm like, oh my gosh, I'm so sick of saying client reported. You can absolutely be creative with your language, but it's also okay because you're covering yourself and the organization by saying, listen, I didn't see this, but this is what's reported to me. This is what I know via my client. Now, there are some things that you will see in session. Client became tearful. Client became, appeared overwhelmed in session. Client had difficulty staying on task, things like that. Usually it's things that we're noticing as their response in session. We also want to include medical conditions and chronic pain. It is not your job to diagnose these conditions, but it's our job to ask. So I always ask about any medications, medical conditions, if they're seeing any specialists. And I specifically ask about chronic pain because we know chronic pain has an impact on our mental health. And for some folks, it is so a part of their everyday life, they don't even think about it. They're like, oh, yeah, I mean, my back hurts constantly. I always have this lower back pain, but I don't even know what life is like without it anymore. But I still want to include that in the intake. I still want to include that in the treatment plan because it's a part of this person's mental health. It's going to affect mental health. I also include any autoimmune disorders, as well as, fibromyalgia, and any birth complications. So if someone has had a cesarean birth, if they've had, postpartum difficulties, that's all included as well, because this is part of the clinical picture. So some clients may be a little vague when it comes to getting at their symptoms. They may say, I have a lot of anxiety, or I get really depressed. And it's our job to ask a little bit of those probing questions. And we say, okay, well, what does that look like? If I were with you during that time, if I were with you when you're really stressed out, when you're anxious, when you're depressed, what would I see? What do other people see when you feel this way? When did it start? How often does this happen? On a scale of 1 to 10, how intense does it feel? How long does it last? When you experience this, does it feel easy to control or really difficult to control? So it's our job to kind of provide these anchors to be able to get a better sense of what the client is going through. Because there's also this subjective experience too. Some clients will come in and they say, I'm just anxious all the time. And with further questions, we realize they're really anxious when it comes to work, or they're really anxious when it comes to performance, or when it comes to evaluation, but they're actually okay in other areas. So it's important for us to ask these questions and to include them in the intake. Now let's talk about medical necessity for a little bit. Now, I know some of you are probably rolling your eyes saying, oh gosh, medical necessity, this is what I hear about all the time, or my supervisor is always talking to me about medical necessity. What does it really mean? Honestly, it's not so bad. Medical necessity is actually used to keep us in check. It's first for medical professionals to make sure they are in check, but also for mental health professionals as well. It's a term that often includes a specific set of criteria that insurance companies use to determine whether or not they are going to pay for a service. It's also used for our ethical boards for estate reporting to make sure that we are, again, practicing with ethical care. Medical necessity is determined by the frequency, severity, and duration of symptoms and the impairment, so how it's impacting the client. So again, if you've done your job well, if you've done your intake where you have a firm diagnosis based on symptoms and the frequency, severity, duration of how this client is experiencing those symptoms, you have nothing to worry about. Medical necessity seems so scary for folks, but honestly, if you have symptoms and how it's affecting your client, you're going to be all right. So, for example, if you have a sprained ankle, it is not medically necessary for you to have surgery, right? Checks and balances, medical necessity. So similar in our work, if you have a client who reports some mild anxiety on the weekends because there's no structure, they're kind of lonely, it is not medically necessary for this client to meet with you twice per week. The symptoms, the frequency, severity, duration, and the impairment on the client do not support that. So it's a way for us to best inform our work, but also to keep us in check. And documenting risk. So this is a whole separate other training, but just as a quick note here, in terms of documenting risk, we need to have a clear understanding of what the risk entails. Now, there are many forms of risk, whether it's risk of completing suicide, risk of self-harm, risk of being not having secure housing, risk of eviction, risk of, trafficking. There's so many risks, but I'm focusing here on suicidal thoughts and self-harm. So when it comes to self-harm, what is a self-harm with? So what are folks self-harming with? How often? Has it ever required medical attention? Because that's going to increase the risk there. And then clinically, I want to know, what is the purpose of the self-harm? For some folks in my clinical experience, it can be a form of punishment. It's driven by shame. It's also a form of self-regulation, whether someone is feeling too much or not feeling anything at all. We need to be curious about what is behind the self-harm, the urge, the function of that behavior. So for the purposes of my clinical work and how I support folks, even past self-harm within the last year is going to be included on the treatment plan, because it's always going to be in the back of my mind. And I like to take a non-judgmental, no shame approach to self-harm. And at some point, if my client says, yeah, I just couldn't take it anymore, and, I engaged in self-harm. Well, I don't want to pull up my laptop and say, okay, well, now we need to change your treatment plan. It's already there. And I tell folks, listen, we're human. Sometimes we have urges. I'm going to put it on the treatment plan because that happens. If we need it, we'll use it. If we don't need it, then that's okay too. Because I don't want it to be a source of shame or judgment if it does happen. And likely it does, and that's okay. It's, a form of regulation and, whatever the function is for that person. With suicidal thoughts, are they chronic? Are they passive? Are they fleeting? They kind of come and go. So for some folks that I've worked with, thoughts of suicide are a form of escape. It's a flee response or a flight response where they say, Dr. Nancy, I don't really want to do it, but it's nice to know that I always have the option, right? Like I always have a way out. That's very different than someone who has a plan and intent and the means to do so. And again, my favorite question is are these thoughts easy to control or difficult to control when you have them? So these are automatically included in the treatment plan and assessed at every session. Now, this goes beyond the purpose of our time together today, but I also encourage you, when you're doing a risk assessment, when you're asking about some of these behaviors, please just don't get out a piece of paper and say, okay, I'm going to go over the screening with you and I'm going to create a safety plan. Try to have it be more of a clinical conversation, because your client's going to see right through that. It's not going to feel like you're really with them. But again, that's a whole separate conversation, but just something to be mindful of and maybe talk to, your supervisor about. Now, the treatment plan, we're spending a lot of time today on the treatment plan because this is where I find folks struggle the most. Treatment plans can be really challenging without a solid framework. And I often see treatment plans where goals are really objectives and objectives are really goals. So I'm going to make that very clear for you today. You're probably going to want to take some notes. So the treatment plan has to be connected to the diagnosis. If it's not connected to the diagnosis, that golden thread has now been broken and we need it to stay together. So if someone has a diagnosis of generalized anxiety disorder, then the treatment plan needs to talk about managing anxiety. Sometimes clients will come in with very clear anxiety symptoms and impairment. And when you ask them about their treatment goals, they say, well, I want to work on my self-esteem, or I want to work on my relationships, or I need to work on getting a job. That's not really connected, but it's our job to find the connection. We are going to work together with our clients to make it measurable, attainable, medically necessary, and most importantly, validating for the client, because we are person-centered. So I know the treatment plan for some folks can feel really annoying, but honestly, it really is your best friend. Your treatment plan is your best friend. It gives you that map for what you're going to do. You always have this checkpoint. I always refer back to the treatment plan. So when progress slows down or you're feeling kind of stuck, you can always go back to the treatment plan. You can pull it up with the client or the person you're supporting and be like, okay, so what are we really working on here? What is my role as your therapist or as your case manager, as this, supportive person in your treatment? Is this really working for us? Is there something we need to adjust? And also, where's our commitment? Right? So sometimes when we're feeling stuck or we're not sure where the commitment is, we can pull up the treatment plan and say, remember a couple months ago when you said you wanted this to get better and you want to work on that? Where are we at with that right now? Because I'm not sure we're aligned. the treatment plan really is your best friend. And if it needs to be adjusted, then it needs to be adjusted, but it's always there to refer back to. Let's talk about the logistics. So with the time frame, treatment plans, so in general, in a clinical setting, it's every 3 months. However, I know I want to be mindful that we're, in the company of different programs and different expectations and requirements. So whatever that time frame is for you. But I also want you to be mindful of other things that may necessitate a change in the treatment plan. So follow whatever time frame is necessary within your program, but also you're going to update the treatment plan and really ethically have to update the treatment plan when you notice that sessions are not following the treatment plan, when a new clinical concern comes up, like now you're noticing depression's getting worse and that wasn't on the treatment plan before, or now some trauma stuff is coming up and you're noticing more PTSD symptoms. You need a new treatment plan. If there's a change in diagnosis, you need a new treatment plan. If there is a risk that has been added, you need a new treatment plan. If there's a change in frequency, duration, or type of treatment provided, a change in that medical necessity, you need a new treatment plan. It's essentially your prescription for what you're getting in therapy. So if someone sees you once a week and now they need to see you twice a week because it's medically necessary, you've included the symptoms and why that's the case, why you've made this decision, well, now you need a new treatment plan. Also, the flip side. So your client's doing better and you're going to kind of space that time out. They need less of your time. They need less services. Well, then you need a new treatment plan because that's going to indicate how the medical necessity has changed. If you follow these expectations, if you follow these guidelines that I'm giving you, you have nothing to worry about because all of your clinical documentation is going to follow your justification. We do a lot of work. We make a lot of clinical justifications in our minds and supervision, but we're not the best at documenting them. And we need to be better about documenting them. So if they're ever subpoenaed, if they are ever requested by an insurance company or by, some state department, then it's very clear why you did what you did. This is your testament. This is, your justification for what you're doing. So getting into specifics about what's a goal, what's an objective, what's an intervention, the goal is typically focused on symptom reduction related to the diagnosis or an increase in functioning related to the diagnosis. The treatment goal always has to be connected to the diagnosis, okay? And the presenting problem. So the presenting problem being anxiety. Let's say the diagnosis is generalized anxiety, or maybe it's PTSD. The anxiety is better understood as under PTSD. Well, now the goal should indicate decreasing symptoms of PTSD or anxiety, increasing functioning related to PTSD or anxiety. It should all be connected. So here are some examples for you of goals. So I included 3 examples here, and we're going to use these examples throughout the treatment plan today. So I have one for anxiety, one for depression, and then one for trauma. So the first one is about anxiety, specifically kind of social anxiety. In the next 90 days, client will decrease social isolation related to anxiety, heart racing, racing thoughts, feelings of panic, avoidance from 2 days a week to 1 day per week. So notice the client came in voicing concerns about anxiety. And they said that they tend to isolate, they tend to cancel plans, they don't want to go out. When they experience anxiety, what does that look like? Heart racing, racing thoughts, feeling of panic, avoidance. And this happens about 2 days per week, usually on the weekend, when this client is like, oh my gosh, I have these obligations that I need to do. I'm going to avoid, I don't want to go out, I don't want to do anything. So we have a clear connection from this goal of decreasing social isolation related to anxiety. So anxiety being the diagnosis. I've included the symptoms, heart racing, racing thoughts, all of that. And then also if I'm decreasing symptoms, I need to know decreasing from what and going to what, right? Like what's the baseline? So decreasing from 2 days a week to 1 day per week. And you can use this formula for really anything, whether it's depression, PTSD, what is the symptom? What is the problem that we're trying to solve? What are the symptoms that we're trying to reduce? And the frequency from the baseline, from what's happening right now to our goal frequency. And the goal frequency is what can reasonably be accomplished within, I'll say, the next 3 months, just for illustrative purposes, but whatever that time frame is for your program, because we don't want a treatment plan that's going to be for the next year. We want them to be small, measurable, attainable goals, because nobody likes to go into that treatment planning session, that treatment plan review session, feeling like they didn't accomplish anything. So we try to make them very small. And if that means we're reviewing the treatment plan at 1 month instead of 3, great. I'd rather review the treatment plan more often than show up every 3 months feeling like we didn't accomplish anything. That's not going to feel good for the client. That's not going to feel good for me as the clinician. Our next example here, in the next 90 days, client will increase self-care and activities of daily living impacted by depression, feelings of worthlessness, hopelessness, amotivation, so lack of motivation, lack of pleasure, feeling pleasure, lack of energy, hypersomnolence, so a lot of sleeping, from 1 activity per day to 2 activities per day. So clients going to increase self-care, activities of daily living. They have been impacted by depression. This person's so depressed that they're not able to take care of themselves. From 1 activity per day to 2 activities per day. Very small. The goal for someone who's struggling with trauma, with PTSD symptoms and dissociation, in the next 90 days, client will experience a decrease in dissociative symptoms. So those dissociative symptoms are disconnection from body, derealization, losing time, related to traumatic experiences from all the time to no more than twice per day. Now you notice the problem that we're tackling here is the dissociation. I connected it still to the diagnosis, PTSD to trauma, right? Traumatic experiences. And I use the client's words here because this is as far as I could get. You know, I couldn't pin down specific frequencies, but the client says, I'm like this all the time. Okay, from all the time to no more than twice per day. So those are examples of the goal. We're decreasing symptoms, increasing functioning, and giving the frequency with which we want to see them. Now the objective. So as I said before, oftentimes I see these mixed. So the objectives are what clients are doing outside of session or outside your time with them to work towards their goals. So this is usually focused on skills use, monitoring behavior, and increasing awareness of trauma triggers or, family relational patterns. Objective, the way that I want you to remember is objective happens outside. When we get to the intervention happens inside of session. So the objective is about what the client is doing outside of session so that they are decreasing symptoms, okay? So now with those same examples of anxiety, depression, and trauma, I'm going to give you what the objectives would look like, okay? Now you're going to notice the golden thread here. It's all going to be connected. Client will practice opposite action, that's a DBT skill, when experiencing urges to avoid social invitations, family gatherings, appointments, etc., related to anxiety at least once per week. So what is the client going to do outside of session in order to be able to decrease isolation and decrease anxiety? The client's going to practice these skills so that, she's not canceling plans. So it's connected to the goal, it's connected to the diagnosis, it's connected to the symptoms. For depression, what is the client going to do outside of session so that the client can decrease symptoms of depression and increase their functioning, their ADLs? Client will practice at least 2 self-care ADLs per day, starting with brushing teeth and taking prescribed medication to manage symptoms of depression. So these are tangible things that the client's going to do 2 things, taking medication, brushing teeth, and then again, I connected it to the diagnosis to manage symptoms of depression. It's all connected. With trauma, client will increase awareness of dissociation through daily behavior monitoring, which, we usually do a chart, and sharing with clinician in scheduled sessions. Client will practice at least 1 mindfulness activity per day to manage dissociation related to traumatic experiences. Usually when it comes to trauma, I have 2 objectives. Because first, we're noticing all the triggers, we're noticing, just increasing that awareness. And I also want them to practice a skill. So we're doing both. They usually have 2 objectives. And these objectives are what the client is going to do outside of session to decrease symptoms. Okay, now the interventions. The interventions are what you and the client are going to do in session so that the client is then prepared to do the objective outside of session. So if the client is supposed to practice DBT, distress tolerance skills, for the objective, then the intervention is that they're going to learn and practice DBT, distress tolerance skills in session. Makes sense, right? It's all connected. When you break it down in this way, documentation is so much easier and you are much better protected in terms of auditing, subpoenas, justifying your clinical decision making, and also just good ethical, good practice. So now let's put it all together. If you're like me, you need to see it all in one place. So in general terms, the goal is to decrease symptoms related to the diagnosis, increase functioning impacted by the diagnosis. With the objective, these are things clients are doing outside of the session to achieve the goal. And then the intervention, this is what's happening inside the session that you and the client are doing in order to achieve the objective. So in reverse order, the things that you're doing in session to teach the client are the intervention so that they can do it on their own outside of session is the objective so that they can reach the overarching goal, what they're trying to improve. Now we're going to put all those examples together. So again, if you're like me, it's more helpful to see it all together. So if the goal is in the next 90 days, client will decrease social isolation related to anxiety, and then all the symptoms there, from 2 days a week to 1 day per week. The objective is client will practice opposite action when experiencing urges to avoid social situations, invitations, family gatherings, appointments, etc., related to anxiety at least once per week. And then the intervention, DBT, emotion regulation skills, which are the opposite action, psychoeducation, supportive listening, validation, problem solving, and maybe other things that you're using as well, maybe some CBT, things like that. For the goal for depression, in the next 90 days, client will increase self-care and activities of daily living impacted by depression, feelings of worthlessness, all of those symptoms there listed, from 1 activity per day to 2 activities per day. The objective, what client's going to do outside a session, client will practice at least 2 self-care ADLs per day, starting with brushing teeth and taking prescribed medication to manage symptoms of depression. And then the intervention, what we're doing in session so the client can achieve all this, collaborative problem solving, psychoeducation, supportive reflection, and probably some CBT as well. Okay, last one here. Let's put it all together with the dissociation goal. In the next 90 days, client will experience a decrease in dissociative symptoms, disconnection from body, all those symptoms there, related to traumatic experiences from all the time to no more than twice per day. The objective, what the client is going to do outside of session to achieve that, client will increase awareness of dissociation through daily behavior monitoring and sharing with clinician in scheduled sessions. Client will practice at least 1 mindfulness activity per day to manage dissociation related to traumatic experiences. And then the intervention is psychoeducation, behavioral monitoring, mindfulness training, DBT mindfulness skills, supportive reflection. All of it is connected. There are no surprises there. Everything makes sense. So with documenting risk, I wanted to include this example as well, because this can feel a little tricky. So the goal is to decrease self-harm behavior from 3 times per week to once per week as evidenced by client report. I would also like to include there the diagnosis. So self-harm behavior related to trauma, self-harm related to depression, to anxiety, whatever it may be. It's not bad that it's not here because the risk is its own section, but it would be even better if it were directly connected to the diagnosis. The objective, the client will utilize the stress tolerance skills to manage urges for self-harm at least 3 times per week and as urges arise. The goal, so this is another example, client will increase use of distress tolerance skills to manage distressing emotions that lead to urges for self-harm. The objective, client will practice distress tolerance skills and emotion regulation skills at least 3 times per day to increase emotional resiliency and decrease vulnerability to distressing emotions and urges for self-harm. That gives a little bit of context of why this person is self-harm, because they're not able to regulate their emotions. Okay. We're going to talk about progress notes. Another tricky one. So a progress note includes the subjective, the objective, the focus of session, and how it's tied to the treatment plan, your medical necessity. And then it includes the plan for next time. So every progress note should be connected to the treatment plan. If you find that session after session, meeting after meeting, it's not connected to the treatment plan, then we need to reorient the client to the purpose of our time together, or we need a new treatment plan. So this is your typical SOAP note: subjective, objective, and then assessment and plan. But I like it broken down in this way. So how did the client present? This is standard. What did the client report? Put that in quotes. What did they report about their symptoms more specifically? This is the subjective, what the client reports. What did you do? The interventions, and what did you see? That's the objective. The objective is client became tearful. Client had difficulty expressing emotions. Session focused on learning and practicing DBT skills, or, highlighting relational patterns that keep coming up within client's relationship. That is objective. That is what happened in the session. And what did you do? Those interventions, as I said. Why did you do it? So how did the client present? What did you do? Why did you do it? So how is it tied to the treatment plan? How is this connected to medical necessity? So if you are bringing awareness to relational patterns, why did you do that? So session focused on highlighting patterns in relationships that cause distress for client, that contribute to anxiety, that contribute to depression. So you have to add that link there. It's not enough to just say, this is what we did. You have to say why you did it, why it's medically necessary, because it's connected to the symptoms, because it's connected to the diagnosis. And then how did the client respond to the interventions? Were they engaged? Did they participate? Were they silent? Did they leave your office? Did they tell you that this is a waste of their time? Did they become tearful? Did they have any noticeable difficulty in engaging in these practices? And then what's the plan for next time? So here's an example of a progress note. Client reports continued anxiety, hypervigilant, heart racing, racing thoughts regarding living at home with mother. She reports feeling like she can't do anything right and is always on edge. This is a great subjective report. So the client reported on symptoms, gave specifics, and she gave me some quotes about, I can't do anything right, and I feel like I'm always on edge. This is connected to anxiety, right? Because folks who experience anxiety feel on edge. The objective, so what I observed and what happens in session, including the client response. Session focused on learning and practicing nervous system regulation skills, including DBT distress tolerance skills. Session also focused on discussion of establishing boundaries with mother regarding time and expectations. Client appeared and reported feeling, quote unquote, not ready to communicate boundaries with mother. This will continue to be revisited in future sessions. So I also like to include that as well. So if my intervention didn't land well, because, that happens, it didn't land well, or the client clearly isn't ready, or, they're like, get out of here with that. I'm going to include that. And I usually, the way that I say that is, this will continue to be revisited in future sessions. Just so it's documented that I did it, I'm not going to forget about it. I'm going to keep on keeping tabs on this. In terms of additional information or assessment, sometimes I leave that blank. Sometimes I include my interpretation. So sometimes I will include, client reported that she wasn't ready. However, this is still progress, as, in prior sessions, client would dismiss any discussion of boundaries with mother, so I might include an assessment or interpretation, especially when it comes to progress. Like, this is actually a sign of progress. She didn't tell me to go F myself. She actually listened to me. She said she's not ready, but she's not, she didn't completely shut me down. And of course, I'm going to say that in clinical language, that she was actually open to hearing what I had to say. And the plan, continue to practice DBT distress tolerance skills, will continue to provide psychoeducation regarding boundaries and assess readiness, willingness to practice skills with mother. That is the plan for our treatment. Some folks will include the plan, we'll meet next week at this time. That's perfectly fine to include that in the plan. I wouldn't have that as the only thing in your plan. We need to talk about, clinically, what's the plan, not just when the next scheduled session is. So another example here, subjective, the client's report. Client reports continued symptoms of depression, including low mood, lack of motivation, lack of energy. Client reports alcohol use 3 times since last session, 1 beer at night before bed. I'm not usually working with folks who have substance use disorders. So if I were, I would go into more detail here about what the use is and, have more of an assessment there. The objective, what you observe and what happens in session, including the client response. Session focused on identifying small changes that can be made with regard to increasing positive experiences, behavioral activation, scheduling activities to improve mood. This is the DBT skill opposite action. So I will include the specific skills. Provided psychoeducation regarding alcohol use and depression, because alcohol is a depressant. Although client has reported reduced alcohol intake from 2 beers every day to 1 beer 3 times per week, she continues to struggle with insight into alcohol use and prolonged depressive symptoms. I would probably include that more in the assessment phase, but it's fine here too. And then the plan, continue to practice CBT and DBT skills to manage symptoms of depression, continue to assess alcohol use, continue to provide psychoeducation regarding alcohol use and depression. So again, especially if something doesn't really land well, their client's just not there in terms of their ability or motivation for change, I will include that in the plan, just so if my records are ever reviewed, it shows that, listen, I'm not forgetting about this. This is still on my radar, and I'm going to continue assessing. With the progress note, make sure you're using active and non-judgmental language. Again, all about non-judgmental language. But we want to use active language, like what are you actually doing? Be mindful of overusing explored or processed. I did all of my clinical training at Yale New Haven, and I had one supervisor, and I'll never forget this. He said, listen, you're not Dora the Explorer. We don't get paid to explore. Use something else. I was like, okay. So I had to be more creative with my language. I'm going to give you some examples, don't worry. But also give yourself credit for the work that you're doing. I know so many practitioners are doing amazing work, but they just don't have the buzzwords. They just don't have that clinical language, right? I'm going to give you some of that too. And I want you to remember the elevator pitch. This is something that has completely changed the game for me. This is something that I use with clinicians, with supervisees, because I notice when I'm reviewing documents, the problem isn't that people are not writing enough. It's usually that they're writing too much. Usually folks are giving a play-by-play about what happened in session. There's a lot of fluff. We do not need all the details. We do not need all the fluff. We need broad strokes, kind of what happened. We want to be concise, but still have details. We want to include general themes, because sometimes it's not in your client's best interest to have all those details in there. So it's also, it's to make your life easier, but it's also to protect your client. So with the elevator pitch, what I tell folks is, listen, if I saw you in the elevator and I said, hey, how was your 9 o'clock session? You're not going to give me a play-by-play, right? You've got 90 seconds before we're at our floor. You're going to say, yeah, my client came in, she was pretty anxious, so we did some skills and she seemed to really enjoy it. She said she reported feeling a little better about that. So we're going to continue more of that. That's a great start to your note. Like, those are the bare bones. That's your note. You're probably going to add a little bit of some of that verbiage in terms of some active language, but that's your note. You don't have to talk about client said this and clinician did that. So then client did this and then clinician did that. I see that a lot. It's not necessary. I also think it might have something to do with collaborative documentation. I think collaborative documentation is great. It can save us a lot of time. But I know every brain works differently, right? So for me, I need some distance from my notes, because if I try to write a note in the moment, or I try to write it right after the session, I'm too in the weeds. I'm too in the details. I need to zoom out a little bit and think about it in the big picture. Like, okay, what did we do? What was the point of that session? And then I can write the note. So if it's possible within the structure of your program, because every program is different, every practice is different, an organization is different, but also think about how you work best. So again, some people, I'm sure they can do it right away. For me, I need a little bit of distance, but that's just me. But think about the elevator pitch. How would you describe this note in 90 seconds or less? game changer. So give yourself credit. So, you might want to take a picture of this because this is going to be really, really important in terms of the work that you're doing. If you're working on emotion regulation, affect regulation, those are great buzzwords, but that's also CBT and DBT. So there are many practices, organizations, governing bodies that want to know, what evidence-based work are you doing? And some people are like, I don't know, I don't think I'm doing anything. You are. I promise you are. We're all doing evidence-based work. We're just not calling it that. Or we're calling it one thing and not something else. So you just need to know what the buzzwords are. You need to know what the clinical modalities are. If you're working on behavior regulation, if you're working on self-regulation, that's also DBT, CBT. Cognitive regulation, again, CBT, DBT. They're pretty broad. Interpersonal regulation, DBT, relational psychotherapy, nervous system regulation, DBT, CBT. You're probably doing a lot more CBT and DBT than you think. If you're teaching cognitive flexibility, you're moving away from all or nothing thinking, that's also CBT and DBT. Perspective taking, when we're saying, I wonder how this person felt about that, or I wonder if we went in this person's shoes, what that would be like. That's DBT, also CBT, and that's also relational, interpersonal psychotherapy. Reestablishing commitment strategies, DBT, CBT, also motivational interviewing. Reorienting to treatment goals, that's CBT, DBT, and MI, motivational interviewing. Imaginal rehearsal, when you say, okay, so when you go to this party and, people have alcohol there, how are you going to refuse? That's imaginal rehearsal. You're like, oh, I'm just talking to this person. That's imaginal rehearsal. That's CBT and DBT. Creating a COPA head plan. You're all creating COPA head plans. You just don't know that that's what it's called. That's CBT and DBT. A COPA head plan is when you say, okay, just like I talked about before, the weekend's coming up. How are you going to regulate before? What's your exit strategy? How are you going to take care of yourself afterwards? That is a COPA head plan. Identifying and assessing values and value-driven behavior. That's CBT, DBT, ACT, acceptance and commitment therapy, also person-centered. It could be existential. It could be gestalt. I mean, there's so many labels that we could throw on this. This is one of my favorites. Allowing emotional experiences. So when you allow someone to just feel their feelings, to be in their feelings, you are allowing emotional experiences. You are practicing mindfulness of emotions, right? We're not trying to change it. We're not trying to get rid of it. We're just sitting with it. We're accepting it. That's DBT, CBT, ACT, acceptance and commitment therapy. It's also emotion-focused psychotherapy. So use action words. So normally I have pages of all this, but for the purposes of today, and just to kind of give you a side note here, this is a 3-hour training that I've condensed into about an hour-ish. So there's a lot more where this came from. So I usually have pages of this, but for action words, again, you might want to take a photo of this. Practiced, identified, assessed, collaborated, provided, utilized, engaged, rehearsed, validated, normalized, highlighted, observed, described. These are all action-based words that we can use to make our documentation a little bit more clinical, to refine it a little bit. I think that's another challenge with a lot of practitioners I work with. They're like, I don't know how to make this sound more professional, or, how to put this in nicer language. Here are some buzzwords. Okay, so some other action words that we can use is to kind of describe your interventions. Practiced identifying emotional experiences, describing emotions, labeling emotions. That's when we are trying to pinpoint what we're feeling in the moment. These are the buzzwords that you can use to describe that. Provided supportive feedback regarding fill in the blank. And that's what we do. We provide supportive feedback. One of my favorite is, and it's towards the end here, empathically challenged. We kind of challenge our clients a little bit, but always from a place of love, always from a place of empathy. Clinician empathically challenged client to think outside of black or white thinking, or to take some perspective taking, practice perspective taking, practiced imaginal rehearsal, collaboratively created a COPA head plan, identified relational patterns. We do that all the time, but we're not giving ourselves credit for it. When we're like, I think we've seen this before, right? This came up with this person, or I wonder if, this dynamic in this relationship is the same as what's happening with your mom or your sister, whatever it may be. We are identifying relational patterns. Okay. Now I saw there's a question here. I will not be sharing my slides today, but you're welcome to take a photo of whatever seems helpful to you. The termination summary, and I also want to leave plenty of time for questions because usually with documentation, there's a lot of questions. So I want to be mindful of time. With the termination note, the discharge summary, it can be helpful to complete a quick review of the medical record to remind yourself of the reason for initiating treatment, the treatment goals, and to kind of gain some perspective, right? Like, okay, this person was here for 6 months. They were here for 6 years, whatever it may be. Let me kind of take a broad strokes view, some perspective here. Let me zoom out and see what we actually did here. I find it really helpful when I'm doing a discharge summary. I have a tab open with the client's record. I have a tab open with the treatment plan, and then I have a tab open with the termination summary. So the general kind of medical record just to look through, and then the treatment plan, and I kind of go through the treatment plan and the intake because that's where we're going to get the most information. So think of an overall summary rather than point by point by point. Now, some termination summaries are going to be much more thorough and detailed than others. So here I'm saying, listen, you don't need to go point by point, but for some clients, you might need to, right? It might be beneficial for them for you to go point by point, meaning, in this session, client was engaged, they were doing this, and then there was this big life stressor, and then that affected their attendance or affected their engagement. So especially if I'm really rooting for my client, if I'm trying to defend the work that they've done, depending on who's going to receive this document, I may be more thorough. So that's an important question to ask. Who's getting a copy of the termination summary? What's the purpose of its use? Is it going to a state body? Is it going to probation? Is it going to medical providers? Is it going to DCF? Whatever it may be. We want to make sure that it's even more thorough to support all the work that the client did. You're going to want to document attendance challenges. So if there were attendance challenges, I usually document just as a standard, client attended 26 sessions out of 50 scheduled sessions. That's not a great attendance rate, but I'm also going to give justification why. I may say there were transportation barriers, there was childcare barriers, whatever it may be, or just to indicate that the client wasn't ready and, they no called, no showed. But it's important to include any attendance challenges and how many sessions they actually attended. You also want to include psychosocial, other stressors, and barriers impacting the course of treatment. So again, if there was childcare, if there was transportation challenges, if the client lost their job and now they had, they lost their insurance, if they experienced a loss in their life and that made it really difficult to commit to treatment, those are going to be some things that I add there because I want to add some context. But then there are going to be some termination summaries that are just pretty straightforward. They came in at this point, they were looking for services at this point, and they were diagnosed with this. This is the treatment goals. This is what we worked on. This is the progress that was made, and they're being discharged. So some are going to be really simple and straightforward. Others, you're going to be spending more time on them, and you want to add more detail because of who's going to receive it or the purpose of it, who it's going to. And, especially when we are, I say defending the client, but you know what I mean? Like there are some times where I know my client needs this treatment summary to be really comprehensive and thorough because we're supporting more services or we're supporting, in other ways we are advocating. And that doesn't mean that some clients deserve more than others. That is not what I'm indicating here. It's in terms of what's necessary. Like there is a standard, but then there are some clients that we're going to include even more because of, how we're advocating for them. So as a general rundown for the termination summary, you want a demographic statement. So that's the statement that we normally use. Client is a 45-year-old cisgender white married man currently living in Hartford with his 3 children. That's the demographic statement. The reason for starting treatment, client had an elevated PHQ-9 score at his well visit and was recommended for services. Client completed intake on this date and was diagnosed with major depressive disorder. Then you're going to go into the treatment goals. What did you agree on? Now, it doesn't mean that you have to go into every single treatment plan and write the goals, but what are the general goals? To decrease symptoms of depression, to increase emotional resiliency, to increase skills use. The objectives, the interventions, again, in general, a summary. The client's response to interventions and the overall treatment. So was the client engaged? Did they participate? Were they able to utilize skills? Were you noticing progress, whether it was in managing symptoms or relationally, or just how they're navigating psychosocial stressors? Any barriers to treatment? Reason for, I should say termination, reason for termination, and then recommendations. We always want to include recommendations, even if the recommendation is client can return to services if clinically indicated in the future. Okay, so here's an example of a termination. No, I'm just giving you a couple examples here. Client is a 22-year-old Cuban cisgender single woman currently living in New Britain with her 2 young children, ages 3 and 5, who was referred to treatment by her general physician after an elevated PHQ-9 score at her well visit in January 2023. So see, I'm including the dates here. At the time of intake, 2/1/23, client presented with depressed mood, became tearful when discussing her mental health, reported lack of motivation, difficulties with tasks of daily living for several months. So I included the symptoms and the presenting problem. She denied symptoms of anxiety, trauma, or other mental health concerns. She was diagnosed with major depressive disorder. Client's treatment plan included decreasing symptoms of depression, including low mood, lack of motivation, etc., from all day, every day to no more than 3 times per day. She engaged in weekly therapy sessions with this clinician, in which sessions focused on CBT strategies to challenge depressive thoughts, as well as behavioral activation and DBT skills to manage overwhelming emotions, and interpersonal effectiveness skills to manage challenging relational patterns contributing to depressive symptoms. So even when we talked about, her boyfriend, who was a big challenge and wasn't healthy, and we talked about, her family of origin, I can include it in the summary that it was still connected to how it was impacting her depression. So again, that golden thread, it's always connected to the diagnosis. Client responded well to interventions and made significant progress with the addition of medication, and then you would include the name and the dose. Client attended 16 of 20 scheduled sessions. Client reported improved mood, motivation, and secured full-time work. Based on progress made and her work schedule, successful termination is clinically appropriate at this time. Client has an established maintenance plan and can return to clinician in the future if clinically indicated. So if someone is discharging successfully, they've completed the program, whatever that may look like, I always indicate too that the client has an established maintenance plan. So that maintenance plan being, okay, who are your supports? Who are you going to reach out to? If you start to feel down, if you are in crisis, who do you call? Like, that's going to be the maintenance plan. How do you know when you need to come back? That's part of the maintenance plan. Okay, some last thoughts here. Take your time with the client. This is part of the engagement and rapport building process. Some clinicians feel pressure to jump into the work right away, and they're like, oh, I have to do this intake, or oh, I have to do this treatment plan. That is the work. That is part of the engagement process. That is part of the rapport building process. If you treat it as an annoying administrative task, your clients are going to know, and they're going to feel the same way. But if you treat it as, okay, this is part of our work, and this is my ethical responsibility to you to make sure we stay on track, and that, I'm providing the best care possible, and that we can always adjust, they're going to feel that differently. Some medical records are going to be more detailed or more vague than others, depending, again, on where it's going, or, if you have a high suspicion that it's going to be subpoenaed, which some people, you may say, listen, any of my records could be subpoenaed based on the work that I do. Okay, then you're going to have a delicate balance of, you want to be detailed enough to support your client, but also vague enough that you're not breaking their confidentiality, that you're still respecting their privacy. That is a delicate balance. Don't hold yourself to unrealistic expectations. You don't need to recreate the wheel with every treatment plan, but they do need to be client specific. So I know some folks, they kind of have a template-ish, it's like, okay, well, if with anxiety, we're usually working on these things. With depression, we're usually working on these things. So it's not like you have to recreate something 100% every single time, but they do need to be client specific. Use common phrasing with client-specific symptoms and skills. That's a good balance. Like I said, with the buzzwords, if you can work smarter, not harder, right? Like we can use these buzzwords and we can use these interventions that I showed you earlier to kind of make those shortcuts more efficient rather than, relying on shortcuts in terms of our language or our judgments. Don't be too reliant on a history button if you have that. Some electronic medical records have a history button or a previous button. That may be good just to kind of get a sense of like, okay, what did we do last time? Or what was most salient last time? But don't just copy and paste them. And then I have to mention AI, artificial intelligence can be a helpful resource for a lot of folks, especially for folks who struggle with documentation, but it is not a standalone tool. I know there's one clinician who relies on AI that I supervise, and it is so obvious to me the difference between the notes that she writes from her own brain and the notes that come from AI. It's very clear. And to me, in my mind, that's just a red flag for auditing, and it's going to get you into some trouble. So it can be helpful if you're stuck with wording. AI can be helpful to kind of allow you to think a little bit differently, but just don't use it as a standalone tool. Okay, I would love to stay in touch. Here are some places where you can find me. My website, drgrechko.com. My email is nancy@drgrechko.com. I am most active on Instagram, dr.nancy.greco, where I share information about my practice, upcoming trainings, and every month I do a free ticket giveaway, so that's a nice way to give back to the community. I'm also on LinkedIn and Facebook.